how can you tell the difference between a male and a female pelvis on an axial CT? I agree, it can be tricky. I mean, of course, a sagittal makes it much more straightforward, so does a coronal, but sometimes if you do have an isolated axial slice just through the lower pelvis, it can be hard. As Tim said, one of the ways to do it is have a look at the shape. The vagina is opposed anteriorly, so it looks flat when you look at it on an axial slice. So what you'd expect to see is sort of a thin rectangular flat structure between the urethra and the anus. Whereas the prostate is more rounded, has a bit of a characteristic shape. You might even be able to just make out a bit of definition between the transition and the peripheral zones on CT, but of course not as well as MR. And of course, if you come a bit higher at the level of the bladder, at the level of the bladder base, you start to see the seminal vesicle, so that helps as well. If you are much lower, sort of more distally, and it is tricky, also look for other things around that can help, like the soft tissues. Can you make out the labia majora in women? And if it's a male CT, can you sort of see part of the penis coming in? So that's, I think it can be tricky, but try to look for anything that you can find to help you. Okay, so we'll get started then with the rest of this topic. So really just looking now, so having covered the kidneys and bladder and testes, we're continuing with the rest of the male genital tract. So going on to the vas deferens, so this is a diagram which sort of has the vas deferens outlined in color, and you can see that there's different parts to it. The function essentially is that it's a long tube that transports sperm from the epididymis, which sort of curves around the testes, to the ejaculatory duct, and the ejaculatory duct is sort of at the other end and runs through the prostate. So the vas deferens or ductus deferens, both synonyms, starts as a continuation of the tail of the epididymis, and as it ascends up the scrotum, that is the funicular part. The inguinal part runs through the inguinal ligament, and then once it enters the pelvis, it runs backwards and medially, and both vas deferens on either side converge in the center, and then move forwards and downwards, where they both join up with the excretory duct from each seminal vesicle to form the ejaculatory duct. The ampulla is a small sort of dilated segment just at the very distal part of the vas deferens, and that's essentially the storehouse of sperm. And we'll have a look at a bit of anatomy. I mean, it's something that might be tricky to trace through its whole length. You can do, but it might be tricky to sort of point it out and say a single axial slice. But this, however, is calcification of the vas deferens, which most often is associated with diabetes, so that really shows the root quite well. So this is a coronal section through the groin, so you can see the femoral vessels on either side here. So presumably the scrotal or funicular part, inguinal segment, and then the pelvic segment running in medially. Here's also an X-ray which shows them calcified, and you can see sort of the distal pelvic parts converging together, and there's also a bit of incomplete calcification of the seminal vesicles. So moving on to the prostate gland. So we'll be looking at prostate gland anatomy in terms of sort of the zones of the prostate. So prostate's essentially divided into 4 zones: the central zone, the peripheral zone, the transition zone, and the anterior fibromuscular stroma. As we sort of covered with the vas deferens anatomy, this is sort of the internal anatomy of the prostatic urethra, which the ejaculatory duct drains into at the verumontanum. When looking at the prostate, I mean, it's sort of a pear-shaped gland. The upper part of the gland is called the base, which doesn't make it helpful at all. But I just remember that by remembering that the upper part is the flattest part of the prostate. You then have the mid-gland, and sort of the narrowest part, which sort of forms a point, is called the apex, and that's the lowermost part of the prostate. We'll be looking at anatomy at the base, at the mid-gland, and at the apex. And just here's another diagram that just goes through the zones again, but from top to bottom in axial slices. So as you can see, the yellow part, the transition zone, does take up quite a large part of the prostate, and the peripheral zone curves around it. And the anatomy at the base is probably the most complex, because you also have an additional zone, which is the central zone. And these sort of brown circular structures here that you can see are the ejaculatory ducts that go through. And of course, the urethra is here, more anteriorly, passing through the transition zone. Also have the anterior fibromuscular stroma, and like its name, it is a sort of a fibromuscular stroma that runs through the anterior aspect of the prostate. Just a note to be aware, so the transition zone is also the part of the prostate that enlarges with age. So with age, the hypertrophic nodules start to build up in the transition zone, and that's what contributes to benign prostatic hypertrophy. And as this central transition zone expands and gets bigger, it stretches and pushes the peripheral zone outwards and stretches it out. So often you can get a transition zone which is really quite enlarged and coming all the way out to the periphery. So as promised, starting from the base, so here's the very upper aspect of the gland, even just above the level of prostatic tissue, you can very clearly see the seminal vesicles, which are sort of lobular with multiple cystic components. They contain seminal fluid, so they are bright on T2 and dark on T1. You can also see the base of the urinobladder here and the distal urethras joining at the VUJ, vesico-ureteric junction. Here is another image, another axial MRI image of the base of the prostate. So at this level, you can see both of the ejaculatory ducts. And as I said, sort of this area that's starred around the ejaculatory ducts is the central zone. And that's often seen as sort of a symmetric sort of central dark area. Peripherally, you have the transition zone, and then these brighter areas here are the peripheral zones. The transition zone is, on T2 at least, the transition zone is darker, and the peripheral zone is brighter. On T1, there's not as much differentiation between them. They're all quite low in intensity, so it's unlikely that you'd get a T1 image to differentiate the two. Here's a coronal image taken through this section here, and that again just gives you another outline of the central zone. So it's central, it's sort of symmetric, paramedian, dark, low intensity area, and the peripheral zone surrounds it at this area. And of course, to actually include the transition zone on a coronal plane, you'd have to come a bit more anteriorly, sort of to the level of the urethra, including more of the bladder. Coming to the midgland, so in the midgland you can see the definition between the transition zone really well. You can see the typical hypertrophic nodules. There's usually a central division of tissue in the middle, which is normal, and then the anterior fibromuscular stroma is seen really well here as sort of an anterior triangular area that sort of stretches across the anterior aspect of the gland. You can see the peripheral zone here, and of course in this patient you can see how it is quite flattened, as they have a few nodules. Little low intensity structures at the posterolateral aspect of the gland represent the neurovascular bundles, so all important structures when you're looking at cancer and where it's involving, and structures that it's involving. And don't forget sort of the well-defined capsule around the prostate, which is also another thing that can be labeled. So coming yet further inferiorly towards the apex of the prostate. So again, the key things to differentiate here are the transition and the peripheral zones. And as you come lower yet, I mean, remember that the prostate sort of stretches down a lot further, all the way down to the base of the urethra, so you can see a bit of prostatic tissue around the urethra here. And of course, that's the rectum inferiorly, posteriorly, and that's the urethra. So the prostate gland can be seen transabdominally. Volume can be measured in that way. Best assessed with the empty urinary bladder, as I'm sure you all know. The fluid in the bladder acts as an acoustic window and sort of causes acoustic brightening deep to that structure. So we can see the prostate gland really well. So circular hypoechoic structure, and although not always seen, in this case you can see the seminal vesicles quite well. So I think that's quite another structure that would be fair for you to know. And then rotate the probe in an anti-clockwise direction and we get a transverse view. Of course, the previous one being a longitudinal view. And on the transverse view, the prostate looks as expected. So rounded structure behind or deep to the bladder. And as you scroll the probe superiorly, I'm sure you would start to see the seminal vesicles coming in, so triangular structures on either side. This is transrectal ultrasound of the prostate. So that's another way to image the prostate, and it's usually, well, it's more or less done in the context of prostate biopsy. Patients might either have systematic biopsy where samples, cores are taken from quite structurally from lots of different segments of the prostate, or they might have a fusion biopsy where a particular lesion that's seen on MR is targeted and fused with the ultrasound images to make sure that it's sampled. On transrectal ultrasound, again, you can delineate the different zones, the transition zone, which again appears hyperechoic on ultrasound, and the peripheral zone peripherally, which is brighter on ultrasound. I think sort of structures like the central zone or anterior fibromuscular stroma would be difficult to delineate, at least for the exam on a transrectal ultrasound. But yes, if you do see the seminal vesicles and the distal aspect of the vas deferens, that's also fair. So the blood supply of the prostate is as follows. So prostatic arteries mainly come from sort of derivations of the internal iliac artery. They might be branches of the internal pudendal. You also get branches of the middle rectal arteries coming in. And this is sort of key in, of course, it's significant in prostatic artery embolization to treat benign prostate hypertrophy. Venous drainage is quite similar, so a prostatic plexus is formed around the prostate and these drain into the internal iliac vein. So moving on to the penis, so structures are as follows. So there's sort of paired structures on either side, the corpus cavernosum or corpora cavernosum in plural, and the corpus cavernosum, corpora cavernosums are present sort of on the dorsal aspect of the penis, and ventrally you have the single sort of midline corpus spongiosum. The corpus spongiosum also contains the penile urethra, and we did see previously the dilatation at the end, which is the navicular fossa. Just some anatomy to be aware of. So the root of the penis is formed by these structures here. So both of the corpora cavernosums sort of come from two crura on either side. So the crus of the penis on either side attaches onto the ischial tuberosity of the inferior pubic rami, and then the bulb of the penis is sort of the proximal most aspect of the corpus spongiosum. All things that you would be able to see on anatomy. The corpus spongiosum, of course, are the structures that fill with blood during erections. And this is a really good sort of coronal plane through the penis that shows the structures quite well. The blood vessels are important to remember. I think these are structures that you can see quite well on MRI or ultrasound. So within the corpus cavernosum, there's a cavernosal artery of the penis, which is quite central. Within the corpus spongiosum, there is a penile urethra. Each of these structures is covered by a fibrous sheath called the tunica albuginea. You've heard this term before with the testes as well. So tunica albuginea covers the corpus spongiosum, and then you have a separate tunica albuginea of the corpus cavernosum as well. And all of these structures are then have yet another outer lining, and this is the blue structure here, which is the fascia of Buck, and that's another thing that may be labeled. Dorsal to these structures, you have a few blood vessels, so the deep dorsal vein and the dorsal arteries of the penis as well. So yes, that's sort of the main anatomy to know there. So we'll look at some imaging. Here is a sagittal view. So you can see the corpus spongiosum. This is a midline sagittal view, as you can tell sort of by the orientation of the bladder. We're midline, so you know it's midline because we can see the urethra as well. Pubic symphyses centrally. This is a corpus cavernosum, and then ventral to that is the corpus spongiosum, and you can see the bulb posteriorly as well. And here's the coronal view, where again you can see these structures: corpus cavernosum, corpus spongiosum. The urethra is this little sort of hypo-intense area there, and you can also make out the cavernosal artery as well as the other vessels dorsally. But I think it would be difficult to differentiate them in this particular frame. They're enveloped by the tunica albuginea, which is low T2. Remember, the corpus spongiosum has a separate tunica albuginea, and all of them are covered with fascia as well. Just another few more structures you can see here. So spermatic cord, and also remember inguinal nodes. I mean, they can really give you any structure as long as it's identifiable. So here's another axial section that shows the root of the penis really well. And as a reminder, by root, we mean both crura and the bulb. So corpus cavernosum, as we move sort of proximally, that becomes the crus of the corpus cavernosum on the right-hand side here. I can see it attaching to the bone. And then centrally, we have the bulb of the corpus spongiosum. This is completely erroneous, so it's obviously not pointing to the septum penis. Please ignore that. And of course, you can see the spermatic cord within the inguinal canal there. Okay, another look at another sagittal view. This is definitely not midline sagittal, so we can see the urinary bladder, we can see the seminal vesicles, we can't see the urethra. This is not the pubic symphysis. It looks more like a pubic ramus sort of moving as we move laterally. So this is actually a parasagittal view. And in this particular view here, we can see a testis, we can see an epididymis. The epididymi are sort of intermediate in intensity, and you can sort of recognize them by how they curve around the testes. You can see more of the spermatic cord. And here, this structure here, it might be a tricky one. I think it probably is a tricky one, but this is the crus of the penis. It's, of course, separate to bone, but of course, we're coming back to where it does have its attachment. Okay, so that was the male genital system. We're completed, so we're moving on to the female genital system. So we'll do a quick overview of the structures. I'm sure you're all familiar with them. So we have the vagina, the cervix, and the uterus. I mean, technically speaking, the uterus is sort of composed of the uterine body and the cervix, but they do get sort of referred to separately. The uterine ostium, or the cornu, where the fallopian or uterine tubes open into the uterus, and then above the level of the cornu, that part of the uterus is called the uterine fundus. And then bilateral paired ovaries on either side, which are in contact with the uterus by ovarian ligaments. The uterine isthmus is another sort of little landmark just to be aware of. So as the uterus starts to converge, the narrowest point before it moves out to form the cervix is the uterine isthmus, and the isthmus is often at the level of the internal os, as that's where you get the change in caliber. So a quick note on the peritoneum. So the peritoneum is not a fully closed sac in women. Some of the pelvic structures, which are extraperitoneal, are sort of open to uh, to the intraperitoneal space in some areas. But for the most part, most of these pelvic structures, sort of the rectum, anal canal, bladder, and the female genital system, are extraperitoneum. So the peritoneum covers the anterior bladder, so it reflects across the anterior aspect of the bladder, back onto the uterus, and sort of posteriorly off the anterior rectal surface as well. And this forms spaces that I'm sure you all know. So the anterior space between the uterus and the bladder is the uterovesical space, and the space posteriorly, the rectouterine space, is well known as the pouch of Douglas. And then, of course, you have the presacral space just superiorly as well. Moving on to ligaments, so we've sort of seen how the peritoneal folds reflect on the sagittal plane, but when looking at them, when looking at it sort of in a coronal view, these folds reflect, the peritoneal folds continue to reflect off the anterior and posterior aspects of the uterus and reflect laterally, forming the broad ligament. So the broad ligament sort of contains the tube, the ovaries, important blood vessels. It contains the ovarian ligament, and it carries on laterally and attaches onto the pelvic side wall as the suspensory ligament of the ovary. We also have another structure that sort of that comes out of this peritoneum and moves forward and anteriorly, which is a round ligament of the uterus. We'll come to that again later. And there's also additional supports of the uterus as well. And when I did mention that some parts of the system do open into the peritoneum, this is where. So the lateralmost aspect of the uterine tube sort of just sort of stick out of this broad ligament peritoneum and is partially intraperitoneal. Another quick look at the broad ligament through this section here. So this is a cross section. So again, you can see sort of the ovary, the blood vessels within, and anteriorly you can see the fallopian tube and the round ligaments. Okay, so moving on to some radiological anatomy now that we've covered the basic structures. So this is the vagina, so fibromuscular tube extending from the introitus to the cervix. The cervix partially projects into the vagina to form recesses anteriorly, posteriorly, and laterally. And these can be difficult to see. So I think unless it's really obvious, you may not be able to label them. But in this patient here who's got gel instilled into the vaginal canal, this sort of opens it up a little bit, and then you can see the fornices a lot better. So here's the anterior fornix, sort of the space between the sort of the vaginal walls as they come round, and the cervix, and that's the posterior fornix. On a axial plane, this probably ties in a little into sort of what the question we were answering at the beginning of the session. The vaginal walls are opposed anteriorly, so flattened, and it does tend to have a bit of this characteristic H-shaped appearance when you look at it on the axial planes. And don't forget your muscular anatomy as well. So closer look at the cervix. So have a cervical canal centrally. The stroma of the cervix tends to be, the walls of cervix tend to be a lot darker, and you definitely normally can see the sort of the delineation between the cervix and the uterus in most sort of women of reproductive age. So we have the internal os, which is where the uterus opens into the cervix, and then the external os. And when it comes to the external os, they are sort of labeled as the anterior lip and the posterior lip of the external os, respectively. The cervix is relatively less mobile, and often it is common to see little cysts called Nabothian cysts, and these are follicles that have become blocked and completely normal. And just a quick note that there are sort of longitudinal ridges anteriorly and posteriorly called the cervical plicae palmatae. Maybe a bit of a stretch, but as a question, but you can see them on imaging. Sometimes you can see them on MR, but they're seen quite well in the fluoroscopy as well. So perhaps just something to bear in mind. So this is the cervix in the oblique plane. It's an oblique plane because an axial plane sort of through the pelvis doesn't get you the best sort of cross-sectional view of the cervix. So an axial oblique is often obtained perpendicular to the long axis. So this is an oblique view. You can see the typical dark stroma of the cervical stroma, and sort of everything lateral to it, sort of the intermediate and lighter intensity tissue is all sort of fibrous tissue that we will come to now. So this is the parametrium, and this is fibrous tissue that separates the supravaginal portion of the cervix from the bladder, and it extends laterally between the layers of the broad ligaments. So the uterine artery and the ovarian ligament are within the parametrium, and you can also see it on the coronal plane. And why is it important? Because when we stage cervical cancer, parametrial involvement upstages the tumor. So this is dark cervical stroma, which you expect to see, and this little break here with tumor tissue extending out. The uterine body typically has a zonal anatomy. So there's a central endometrium within the uterine cavity, and that's hyperintense. You have the junctional zone, which is the inner layer of the myometrium, and that's usually dark and hypointense. And then the myometrium itself is a fairly intermediate signal. On the sagittal plane, the endometrial cavity looks slit-like, but when you take an axial plane sort of through it, you can see that it looks rather triangular, and that's of course because you have the indentation from the fundus and then the convergence towards the cornu. Quick sort of note on position, because I know this one can get confusing. So flexion versus version. So uterine version is the angle that the cervix makes with the vaginal axis, and flexion is the angle that the uterus makes with the cervical axis. So this patient has a cervix angled posteriorly, so this is a retroverted, retroflexed uterus, whereas this patient has a anteriorly angled cervix and uterus, so this is anteverted and anteflexed. Quick note about age, because the uterus can look different a lot of the time. So in sort of very, very young, just after birth, you can see an endometrial stripe purely due to the influence of maternal and placental hormones, and that very quickly disappears after the baby is born. And the endometrial stripe doesn't really return again until puberty. So in the reproductive age is when you really get the sort of well-defined zonal anatomy, sort of the central endometrium. This person has a coil, that's why you've got a dark line in the middle that's not normally there. Then you have a junctional zone and outer myometrium, and then you more or less lose that definition following menopause. Everything looks a lot more uniformly homogeneous. So uterine tubes, just cover it really quickly because these aren't really structures that can be seen unless they contain fluid. They have a hydrosalpinx, or unless they're enlarged. So you have the outer infundibulum, which contains the fimbriae, which essentially catch a released ovum. The longest part, which is the ampulla, and the widest. The isthmus of the uterine tube, which is the part sort of coming in towards the uterus, and then don't forget that there's also an intramural part of the uterine tube, which is within the myometrium. Of course, the tube is a commonplace for ectopic pregnancies. So the ovaries, paired female gonads on either side. These lie on the posterior surface of the broad ligament, as we've seen. And a good sort of landmark is to look in between the external and internal iliac vessels. They can be really mobile. And when looking on imaging, the main structures to identify are the intermediate intensity ovarian stroma and the peripheral follicles, which are essentially just T2, hyperintense, bright on T2 and dark on T1. So the uterus has multiple supporting ligaments, sort of beyond the scope of this presentation, not really something that you see on imaging, most of them anyway. So we've covered some of these already, but we'll come on to one of the ligaments which you can often see on imaging and can be asked. So the round ligament, you can see it in this diagram here, extends forward from the anterolateral aspect of the uterus. It passes through the inguinal canal and sort of attaches to the labia majora and the mons pubis. So this is essentially just a soft tissue bound on imaging, and you can see it sort of extending outwards on either side. So this is definitely sort of fair game, I think, for the exam. And a quick note on blood supply. So the ovarian artery comes from the internal iliac, supplies the ovary, and then through this course, through the broad ligaments, it moves towards the uterus, where it then anastomoses with vessels and branches from the uterine artery, and that originates from the internal iliac artery as well. You can see these vessels on an angiogram. So the ovarian arteries arise anterolaterally from the aorta, and they arise just inferior to the renal arteries, but above the IMA. So probably between the levels of L2 and L3. They descend retroperitoneally with the ovarian vein and the ureter, pass through the suspensory ligament, which is part of the broad ligament, and towards the uterus. And you can see in this image here that there are the branches from the ovarian artery supplying the ovary, and you can see them continue to anastomose with the uterine supply as well. Ovarian vein, touch on it slightly. So Tim did mention the anatomy of the ovarian vein, which again is quite similar to the testicular vein. So both the gonadal veins drain into the IVC on the right and into the left renal vein on the left. And a quick slide on the uterine artery, which is a tricky one. I can't imagine you would be asked that, but this arises from the internal iliac, one of the branches of the internal iliac artery, and of course is sort of significant in embolization, which is used to treat large fibroids or postpartum hemorrhage. So go through ultrasound anatomy. So seeing how these structures can be seen with a full bladder. So the uterus, the endometrial stripe is usually bright, so it can be seen on a transabdominal ultrasound. Of course, this is a longitudinal view. You can see the cervix and the vagina, of course. And then posteriorly, you may very well be asked to label either the anus or the rectum. And on the transverse view, the central sort of transverse section of the ovaries, again seen with the central myometrium, and it's very possible to see the right and the left ovary sort of on either side paramedially. Ovarian ligament, not often seen, but may be seen when outlined by fluid. So this is just a characteristic sign, the typhitis sign, where you can see the ovarian ligaments in the presence of pelvic ascites. Okay, so transvaginal ultrasound, really tricky bit of anatomy, something that I know I found quite tricky in ST1, but not so much, to be honest. So the probe is sort of in transvaginal ultrasound is inserted endovaginally. This is sort of the orientation with respect to the patient. So sort of you would expect your image to sort of look like this perhaps when you're getting a sagittal overview. But on the ultrasound screen, it is, of course, oriented so that your probe is at the superior aspect of the screen. So this to the right of the screen is upwards or cranially in the patient, and to the and to the other side of the screen is caudally in the patient. So cranial and caudal, and of course this is superficial and this is deep with respect to where the probe is. So you can see gynecological anatomy really well with transvaginal ultrasound. So here is the probe sitting within the anterior fornix. So remember that's sort of the little recess that's formed between the vagina and the cervix. So cervix here with a bit of fluid in the canal, and you can see that narrowing of the isthmus where the cervix then sort of moves into the uterus. And here's another look at the uterus, so you can see the central endometrium. It can be it does look different according to the menstrual cycle, and we'll go into that really quickly soon. And then, so that's the longitudinal view. And once you rotate the probe anti-clockwise, again, you get a transverse or like an axial view through it. So this is a transverse section of the uterus, central endometrium, and the adnexal structure starting to come off the side. So quick note about endometrium looking different throughout the menstrual cycle. So of course, day 1 of menses, where the endometrium is shed, and following that, the endometrium does start to grow in the proliferative phase, of course under the influence of hormones, and then the second half of the cycle becomes the secretory phase. So we can see this on ultrasound. So often the endometrium is very thin and echogenic in the early proliferative phase. So if you are ever asked to label this bright thin stripe in the middle is endometrium, everything around it is myometrium and the rest of the uterus. In the late proliferative phase, towards the middle of the cycle, you get a really characteristic trilaminar appearance. So central brightness, a bit of hypoechogenicity in the middle, and then it's bright again on the outer layer. And once more than halfway through the cycle, in the secretory phase, everything just looks thick, echogenic, and homogeneous. So again, this is still the endometrium with the outer myometrium. So it's quite fair, I think, to get an endometrium that looks like this, or an endometrium that looks a lot brighter and wider. Ovaries, again, really well seen. So you can see them as these ovoid structures with rather bright echogenic stroma, and then dark follicles containing fluid. You might not always be able to say whether it's the right or the left, but I think if you can see part of the uterus or the ovaries just adjacent to the uterus, you would be expected to say whether it's the right or the left. And of course, dominant follicles can grow quite large. Again, remember me saying that the iliac vessels are a really good landmark to the ovaries, so they will often pass nearby. And this may or may not be something that you need to know, but it is a view that you can get on ultrasound. So this is a probe that hasn't yet entered the vaginal canal, and it's just been placed on the vulva. And actually, in this way, you can assess the distal urethra, you can assess the distal vagina and the anus. So again, rotating that figure so that your probe is at the top of the screen. Here's the urethra, bladder going forwards, vaginal canal in the middle, and of course this is the anal canal because it's angling away and posteriorly towards the external anal sphincter, and of course rectum. So very quick last note on hysterosalpingography, which is of course the fluoroscopic examination, usually done for fertility. The cervix is catheterized, so dye is squirted through into the uterine cavity. It's expected to travel through the tubes and leave the infundibulum to enter the peritoneal cavity. So here's a normal HSG, so cervical canal, and it's a cervical canal because you can make out the narrowing from the isthmus, uterine cavity, both cornu, and then the tubes on either side, and this is contrast spill into the peritoneal cavity, which of course is normal because that is the direction the contrast will take. And just a quick note on the cervical plicae palmatae, so the palm-like folds, that they can be seen quite well on HSG as well. Okay, so hopefully I've not put you all to sleep. I know it's quite late, so thanks for bearing with us.